It's really exciting. I spend a lot of time on the road, or I have for the past 2 years, in front of a couple thousand National Health Service Corps providers coming to conferences like this, and never fails at every session the idea of patient-centered medical home or patient-centered approach comes into play, and there's lots of questions. And so recently we've put together a group of panelists from Clinica who are here to talk about that, because you guys had so many questions about how does that work, what's it supposed to look like, how are people doing it across the country. And this is just one example of how that works really well. I'm so pleased to introduce the Clinica team today. Ms. Jenny Dorman is the Vice President of Operations at Clinica Family Health Services. It's based in Denver. And since graduating from college, she's taken a hands-on, practical approach to getting people the health care they need. She worked with the Peace Corps in El Salvador, where she helped bring clean water and proper sanitation to rural areas. And as Vice President of Operations at Clinica, she uses her passion for improving health systems to help the agency give the best care possible to its patients. She earned her Master's of Science. She earned her Master's of Science in Health Administration from the University of Colorado. And next to her is Lauren Jensen, and Lauren works as a behavioral health professional for Clinica Family Health Services. She's also a participant here in the National Health Service Corps Loan Repayment Program, so she is a current National Health Service Corps loan recipient. And she received her bachelor's degree from John Brown University with a major in Children and Family Studies and a minor's in Spanish and Family and Human Services. She earned a Master's of Social Work degree from the University of Denver Graduate School of Social Work. And then sitting next to Lauren is Dr. Daniel O'Brien. And Dr. O'Brien practices full-spectrum family medicine, including ambulatory, hospital, and obstetric care at Clinica Family Health Services in Lafayette, Colorado. He graduated from the Arizona College of Osteopathic Medicine and completed his residency in family and community medicine at Scottsdale Healthcare in Scottsdale, Arizona. And he's been a National Health Service Corps member since 2011, so please let's welcome our Clinica family.
So I'm just going to tell you a little bit about Clinica and what we do this morning, and then Lauren and Dan are going to share some personal stories about experiences they've had with our patients. So just to let you know, basically, we are located in the Denver metro area. We have 5 clinics. We just recently opened our 5th clinic. So we have 3 clinics in Adams County, in the Broomfield area, and then 2 in Boulder County, right around the Denver area. And we have about 40,000 unique patients, and we see about 190,000 encounters or visits with those patients every year. And I'm not going to go through too many of our demographics. You can see those. But about half of our patients are less than 19. We see a lot of pregnant women, do a lot of deliveries, and our patients are very poor. So 98% of our patients are at or below 200% of the poverty level. So at Clinica, we like to say we have a deal with the devil, and this is probably one of the key components of how we've become and how we are a patient-centered medical home. But a lot of community health centers are located in areas that have a really high need for their services, and access is limited to health care. And so it makes a lot of sense to just want to provide access to as many people as possible and see people for acute services, and kind of crank through patients as many as you can every day to try to meet the need. But what we've decided to do, and I don't think there's a right or wrong here, it's just a choice that we've made, is we try to only take in the number of patients that we feel like we can really provide high quality health care for. So we do limit the number of people that we see in order to be able to do a really great job. So we have panel sizes of about 1,200 patients per clinician FTE, and that means that I think it says we serve about 26% of the target population in our communities. So it's a choice that we've made to be able to do the best that we can for the patients that we do see. So our journey in becoming a patient-centered medical home began almost 15 years ago, and we've been focusing on these kind of 6 things we call the big 6 ever since. And I just want to point out that it has been a really long journey and not something that happened overnight, the way we've become such a patient-centered medical home. And these same 6 things we've been focusing on for a very long time, and they require constant energy and innovation. So the first thing that we really focus on is continuity of care. We assign every one of our patients to a primary care provider, and then they also are assigned to a team, and I'll talk a little bit more about how our teams work later. And we do a lot of things to try to make sure that our patients know who their primary care provider is, and also that when they call to make an appointment that they're able to see that provider. So we really want them to build a trusting relationship with their primary care provider, and then with everybody on their team that is helping them coordinating their care and providing their health care. So I think that's all I have to say about continuity. But we measure it relentlessly. We just try to make sure that we always know how often when our patients call to make an appointment, they actually see their primary care provider. And that helps us with quality because obviously they're seeing the same provider who really knows them well. And it helps us with access too. It's easier for a provider to see a patient that they already know. And so when we're struggling with access, it's just easier for everyone to see patients that they have a relationship with. Number 2 is access. We have a huge focus on making sure that we're able to see our patients when they want to be seen. So we really try to make sure that we have capacity every day to see the patients that we need. Some of the ways that we do that, during the summer we tend to be a little slower. During the cold and flu season, we tend to be a little busier. And so we're constantly thinking of ways to try to pull people towards us and bring people in when we're slower so that they don't need to come in when we're busier. And we're just always thinking about how to plan and manage our schedules. And then the next 3 things on there, or the next 4 things I have different slides for. So team-based care is really important to us. In 1998, Clinica joined the Chronic Care Collaboratives with IHI, and that's when we really kind of started this journey. And we started focusing on diabetes, and we were implementing evidence-based care, starting to bring patients in more often to make sure that they were getting the care that they need. And one thing that we realized was that as we were pulling patients in more often, bringing them in, we had some issues with access, with efficiency. We weren't able to do things as quickly and as efficiently as we wanted to. So we really started to focus on how our system works, who's on our care team, the way that our clinics are set up, how we get patients in to see us. And so one of the things that we really have focused on is building pods and building small care teams. So each of our clinics is set up into what we call pods, and every pod has 3 medical providers, and each provider has a medical assistant. We have 1 medical assistant team manager, 1 nurse team manager, a little bit of who we call a clinic nurse who does mostly just clinical nursing. We have a case manager, a behavioral health professional, office techs who check patients in and do patient registration, medical records, and referral case managers. So you can see that we have a lot of people on the care team, and they all have really important roles. We really focus on making sure that everybody on the team is working to what we call their full scope. So our office techs are helping us to identify who's due for an expert screen. They work our registries for patients that need appointments. We have front desk calling and outreaching our patients. Our case managers are helping our patients set self-management goals. As we work more and more in the accountable care world, we're starting to think about how we work with our patients after they've been in the hospital. So we have case managers that are following up with patients after they've been in the hospital, making sure that we bring them back in and that the care team's ready to handle any of their needs during that handoff. We have BHPs like Lauren that sit on our pods with the care teams and work really closely with our providers to do behavioral health interventions. So it's a huge complement of people that work around our providers, and we really try to make sure that the providers are doing only things that need to be done by our provider and that everyone else is supporting them and providing care in the best way possible. One thing that we've started doing recently is adding hygienists to our pods. So we've also started integrating some oral health care. We have a couple of dental clinics, but we have put hygienists on the pod to actually apply fluoride varnish to children as a part of the medical visit and on the care team. And so this is just our ideal dental pod. We've really started to think about, are there other ways that we can change our dental clinics so that they mimic a little bit more our medical care? Should we have pods? Should we do things in different ways? So right now our ideal dental pod has 3 dentists, 2 hygienists, some expanded duty dental assistants, and then a dental assistant. So delivery system design, we have done a lot of work in setting up our clinics so that they work more efficiently. Our pods are very open so that everybody can always see each other. We call it line of sight. So instead of having provider offices and then our exam rooms down the hall, and we put everybody together in the middle of the pod, and the exam rooms are around them. So at any given time, you can kind of stand up and see, where's my medical assistant, where's the nurse, and you can see your exam rooms and know where the patients are, who's with them, and who needs you next. So that's been a really important piece for us, just for team communication and for being more efficient, is just being able to see each other throughout the day makes a huge impact. And then another thing that we've done is add a lot of group visit space to our clinics. I think we started doing group visits around the year 2000 when we really started to focus on planned care and providing alternative visits to our patients with chronic conditions. So we've really found that when we take a group of patients that have a similar condition, get them all together in a group with their primary care provider so that they can share experiences, learn from each other, and have some solidarity. It's better care. Our providers love it. It's great for access. We can see more patients at any given time. And we've really started to build our clinics to accommodate more and more of these group visits. So every time we do a remodel or open a new clinic, we want to put more and more group visit spaces, which is really exciting. Information systems, we are obsessed with IT. It starts with our EHR and making sure that we're documenting things in places where we can pull them back out and do reporting. We have a lot of templates that help drive evidence-based care. Then we use those templates to make sure that we get information back out. So we have registries for every chronic disease imaginable, for asthma, hypertension, diabetes, depression, chronic pain, and we use that information to make sure that we're outreaching our patients when they need to see us and that we're tracking their outcomes. One really exciting thing we've started working on is, in the past we had a registry for each different chronic condition, and so sometimes we would be calling patients more than once because we often find that our patients are on more than one registry. Excuse me. So one thing we've started working on is just making one giant registry where we can see any one patient and then every registry that they were on in the past and all of the outreach they need at any given time. So as we do more and more reporting, get more familiar with our EHR, think more about our registries, I think we've just become more and more sophisticated at how we work with our patients to take the power of all of the information that we have and use it in the most efficient way. So we assign primary care providers in the EHR. We measure when patients can come in, how easy it is for them to get in to see us, and then we group them by the conditions that they have or the health care that they need, and that helps us to be more proactive and outreach them when they need to be seen. And the better we get at reporting, the more we want. So we've gotten to the point where everything we do at the beginning of a project, we recently implemented a spurt. One of the first questions we ask ourselves is, where do we want this documented in the EHR? How are we going to pull it back out? And that information really helps our managers to know how often is this happening? Do we have workflow issues? Are we doing what we said we were going to do? So we're really good about measuring everything, and that helps us hold people accountable and just know if we're successful at doing what we set out to do. And then the last thing that we really focus on is patient activation. So, as a community health center, half of our board is patients. And so it's part of our roots to be patient-centered and to get feedback from patients and to work really closely with our patients to improve the way that we deliver care. And it's also something that we want to be better at and that we have a huge focus on recently. we've been working with our patients for a long time to set self-management goals and to understand what their needs are, meet them where they're at, build relationships with them to provide the best care. And we want to get better. So we want to include them on our groups when we're implementing projects, on teams to get their feedback. And we've just started to do a lot more of that, where if we have a project where we're implementing, say, medication safety management, we might ask one of our patients on Coumadin to participate on the team and to tell us about their experience, tell us what's important to them, and run our ideas past them. So I feel like we're just starting to kind of get better and dip our toe into the water of really harnessing the power of our patients' feedback and making sure that when we have ideas about something that we want to implement, that we get their feedback up front and not in a your comments count or a patient satisfaction survey later, but engage them in the process of making improvements and understanding what their needs are as we implement new things. So that's just a little bit about Clinica and the things that we focus on to be a patient-centered medical home. And Lauren and Dan are going to share some more personal stories about their experiences with patients.
Good morning. So I'm one of the BHPs at Clinica, and I'm a licensed clinical social worker. And one of the things I love about working at Clinica is that every day is different. I walk into the clinic having a schedule, but that immediately changes. There's lots of variety, lots of things to learn. I sometimes feel like I'm trying to drink out of a fire hydrant. The demand and the need is so huge, but nothing is boring. So before I share more of a personal story with the patient, I wanted to give you a glimpse of some of the referrals I receive. So this is something where it's just another day at Clinica. I got this task from a provider. It says, Lauren, this was a new patient I met. No BHPs available, and the patient couldn't stay. She is under significant life stressors, moved in with daughter after ended relationship with cheating boyfriend who was cocaine addict, reports history of depression, on med in the past, interested in a counselor. I gave her your card. Another one, a task the provider sent me for follow-up, was regarding a person with a history of alcohol and drug abuse, attempted suicide about 10 years ago by using a shotgun. He misfired and shot his right arm off. Many surgeries and skin grafts, 10 years sober, now a drug abuse counselor, would like to speak with you. And then even before I left to come here, earlier this week, I got a message from a patient that I met regarding her chronic pain med management, and she wanted to see me but has had a few appointments that she couldn't make for various reasons. Her family was sick. And she called me and left a message just recently saying, I will give you my credit card number, and if I don't show, you can charge me. And so she did. She gave me her credit card number and was wanting to get in. And so what I love about Clinica is these obviously are just random things that I get to be involved with, but it's also patients that may never want to speak with a counselor or ever want to set foot in a community mental health center. They come in to see their doctor. They will come in always to see their doctor and ask questions, and I get to work with them. And so there's just this beautiful area of getting to work with people that have a lot of need, even if they don't want to talk to me right away. A specific story I'd like to share with you today is regarding a young woman who came to our clinic in one of our group prenatal visits. She walked in, first appointment with a group of other women who were pregnant, and this was her first time in Clinica, 20 weeks pregnant, and while the medical assistant was getting her vitals and doing basic information, demographics, the medical assistant learned that she was pregnant by rape. And so the nurse practitioner was notified, the case manager was notified, and they called me. So I walked downstairs into one of our group visit rooms and met with this young woman who was going through all kinds of things. She didn't want this pregnancy. She just moved to Colorado from Central America. She was going through culture shock. She had some acute stress, trauma reactions, and she was terrified out of her mind. So right from the very beginning, I got to meet with her. And in those 20 weeks following that first visit, the provider and I worked with her every visit. We would meet. We would talk in the visit rooms. We would address some of her life stressors. We would talk and normalize some of what was going on for her, help her identify what options that she might have with this pregnancy. She did move to Denver to live with a relative, so she had a little bit of positive support in Denver, but otherwise was very alone, did not know English, did not even know how to get a bus ride to get home from the clinic. And this woman is just astounding to me. She had such great ideas. She wanted to go to school. She wanted to have this job, all these things, and everything suddenly changed. And by meeting with her, working with her, we could address her health needs with the pregnancy to help her be safe and healthy and take care of some of her high-risk health issues that she had. And we could address some of the stress reactions that she was experiencing. And this was something that might not have happened otherwise. This woman met with an adoption specialist and pursued some of those options and then decided after labor and delivery that she wanted to parent the baby. And now when she comes into the clinic for her well-child checks for her daughter or for her postpartum depression screening for herself, she can look us in the eye and say, thank you for being with me and walking with me through this whole experience. Something that stands out to me is she feels safe at the clinic. She comes in, she knows that she can meet with me or talk with me and her doctor and the nurse or anyone with questions that she has and not be judged for her experiences. And that's been one of those patients that stands out to me is just this victory moment, these stories of someone that's taking care of all of their health. Another one that comes to mind briefly is this young teenage girl who, because of the severity of her depression, I helped her get in to see a psychiatrist and have more long-term counseling at our community mental health center, but has instead come back to Clinica over and over again. And the mom and the dad and this teenage daughter say, thank you, this place is less confusing to us because we can come here and we see all of you. We see our doctor, you have the information from the psychiatrist, I can talk with you about these self-management goals. And I'm not as confused at what treatment plan this person says or this person says, but it's all in one place. And that's something over and over again I hear at Clinica, that we get to work together for the patient. The patient's a part of their team care and their plan. And these changes, sometimes even though they're slow, it's progress that seems to last. And something that's a lot of hard work, as we all know, but it's also a real joy.
Okay. Hey, everybody. I'm Dan O'Brien. I'm a family and community medicine physician and an osteopath at Clinica in Lafayette, and I like to stand up, so I'm just going to stand up for a sec here. First of all, I just wanted to start off and say thank you so much for having us all here to talk to you. You know, we're all very honored to get to come and talk to our colleagues and people doing the same things that we're doing. You know, we're all in this together. I've been a physician for 2 years at Clinica. I do inpatient, outpatient, adult and pediatric and obstetrics, which I don't think I get the chance to do many other places. That's something else I'm grateful for. And I'm just going to put out right there right now, I'm kind of goofy. I like to joke around and take things lightly, which I think is true of most of the people in the room. Except there's always 2 or 3 grumps in anywhere you work. So anyway, we were asked to come up and tell a couple of inspiring patient stories. And it got me thinking of, okay, you know, there's those stories you always remember, but what are the stories that really touch you? And it got me thinking about kind of what it is that we do in community health and at Clinica and what it is that we do in the National Health Service Corps. And when it comes down to it, I believe that what we do at the end of the day is we take the patients in our communities who have the heaviest burdens to bear, emotional burdens, burdens of addiction, abuse, horrible physical illness, and we make those burdens a little bit easier for them. We make it a little easier for them to get through the day, a little bit easier for them to provide for their families and to do what they have to do. It also made me stop and think about kind of how patients come to Clinica. How do you come to a National Health Service Corps provider? How do you come to a community health center? And I think a small majority get there because of bad decisions, and that's where the funny stories come from, right? So I had one lady. She was driving in the hills west of the city, a little Honda Civic or something, and she saw a coyote coming across the road. And she tried to veer to get out of the way, and she clipped its back legs, which is very, very sad. But instead of doing what most of us would do, it would be to say, oh, that's too bad, or maybe if you're from where I grew up in the mountains, you throw the car in reverse and you back over the coyote to put it out of its misery. But instead, she found the coyote, which was limping, trying to get out of the road, and she scooped it up like a baby to comfort it and take it in for care. Now, I don't know if there's coyotes around where you live, but I think for all wildlife in general, the one universal rule is they don't like being scooped up, and they don't like being cradled like a baby, especially if they're injured. So you can imagine what happened. It scraped and bit and clawed and fought for its life. And instead of doing what most of us would do, which is, you know, to drop the coyote and then really put the car in reverse and back over it and put it out of its misery, she threw it in the back seat of her Honda and drove into town. And that's where I got to meet her at the hospital. And she had come through the doors just looking like she'd been through a lot. When the nurses asked, "Oh my God, what happened? You look like you've been bitten and scraped." And she said, "Oh, I was attacked by a coyote." "Attacked by a coyote? Oh my God, did you get a good look at it? Did it look rabid?" Like, "Oh yeah, you can look at it too. It's in the back seat of my car outside." So, actually, there's a tragic ending to the story. Not only did the patient, go through a lot, but animal control actually came out and had to take the coyote and process it, put it down to check for rabies anyway. So, but I don't know, we all live and work around Denver and Boulder, and we're very connected to nature there, and some of us more than others. But at any rate, so I told that story just because the small majority of bad decisions make for, I think, the vast majority of funny stories. But really, most of our patients, I think, end up with us as providers because of circumstances beyond their control, obviously. Circumstances of mental illness, physical illness. Like I said, I'm an osteopath. I think there's a few others. Are there any other DOs out there? All right, awesome. So I take a special interest in the musculoskeletal system, especially as it relates to chronic pain and disability. So I see a lot of back pain. Back pain is a terrible disease. Young, otherwise healthy people of any age, most common cause of disability, 20% or so are new adult visits, back pain. I had a different young lady, not the coyote lady, but a different young lady had come in. She had been an executive at one of the companies around town, had flown to conferences all over the country, giving talks, very much doing well in life. And then one day just happened to be lifting something wrong and popped one of her lumbar vertebrae, herniated disc. L5 was impinging on her lumbar nerve roots. And just like that, she had almost no use of her leg, chronic pain, lost the job, lost her insurance, lost her house, lost just about everything. When she came to meet me at Clinica, she came in with her fiance, and her fiance told me she spent most of the day just looking out the window crying. On kind of her way to see us, she'd been to see several other physicians who'd started her on 60 milligrams of oxycodone a couple of times a day. And she'd also by herself picked up another habit that's kind of a burr in the saddle, at least around Colorado and a lot of different places, and that's medical marijuana. And she smoked a lot of that as well. I don't know how you feel. It's just my own editorializing, but I think if you've got glaucoma, take glaucoma drops. If you've got anxiety, take anxiety treatment. Go to counseling, take anxiety pills. If you just want to smoke pot, but let's not call it medicinal. Feel however you feel about that. All right. So at any rate, she was very much not herself, was what I heard from her family over and over again. So I'm proud to say today that she's back to working full-time. She actually moved on from Clinica. She's back to private physicians, although many of our patients choose to stay when they do well. And I take very little of the credit. When she came in, she first met with our behavioral health providers, which are very, very much appreciated, who tried to work with her to stop going to the pills. Pills are important, but when you're stressed, when you're in pain, don't pop the pill. That's not the best choice. Work on being mindful. Work on other coping mechanisms. How about some yoga? How about some meditation? And it was a hard sell, but we got her to completely quit the oxycodone and the medical marijuana, moved her on to citalopram, 20 milligrams a day, and then Ultram, twice a day scheduled as needed, and for $8 a month, she was herself again. And then I think the great unsung hero of all of our community health centers, the referral case manager, had a lot to do with that as well. She's a wonderful lady, Michelle, who knows how to beg, borrow, steal, blackmail, whatever it takes to get our private pay specialists to get to see our patients. This particular patient was able to get in and have a microdiscectomy and a little bit of therapy to recover. And like I said, today she's doing fantastically. Last time I saw her 6 months ago, she came in just to tell me how well she was doing and give everybody a hug. And she actually said she wanted to volunteer, but apparently she's too busy for that. I haven't seen her around since. She did knit me a scarf, though. It was very nice. So I believe that we, as the primary care doctors, we lift the heaviest loads off of people and make it a little bit more possible for people to do what they need to do in their lives. Jenny mentioned briefly our group visit model, which I think has been hugely successful. It was a big ego check for me and for all of us to be just sitting in the back of the room during the visit with 10 people with diabetes or 10 people with pain. But patients just love it. They get a lot more out of it than listening to me yammer on for the 15th time about metformin and a low-carb diet and this and that. Our 2 or 3 most common group visits, I believe, are prenatal and young children, diabetes. We've also started pain management groups, which have been hugely successful. Some of our providers even do innovative things like have yoga sessions with their chronic pain group. Talk about what can I do other than going to my Percocets, Vicodins, OxyContins for my pain. In the diabetes groups, and people have been bringing up questions that I, from from my place on my doctor's stool with my little computer never thought of. For example, if I eat breakfast as a diabetic and I miss my shot, should I take 2 at lunch? No. But I never thought to tell people that before, and this brings up these questions to me. So just in closing, I just want to say again, thank you so much for having us. We greatly appreciate it. Thank you for what you do, helping to take the burden a little bit off of all of our communities and make it easier for people to really live quality lives. So I think we're going to open up to questions. Thank you.
So like Dan said, we'd love to hear if you have any questions for us about what we do, or we'd like to hear about what you do or similar experiences you've had where you're working. Oh, and there's 3 microphones set up in the middle of the room here. If you have a question, if you could.
I was just wondering, you said that this has been a long process and everything, and now that you're established, are you starting to see generations of families? Are they able to come back in?
We do. I mean, you guys might be able to answer that better. I've definitely heard lots of stories from our providers about being able to see various generations of the same family, for sure.
And I've been at Clinica a little over 3 years, and with the providers that I've worked with, just getting to take care of their families and the history they get to know, the kids coming back in, and so it is a long history, and it feels like you get that broader picture of knowing someone's history, and a lot of people that come to Clinica want to stay, and then their kids get involved too, and then their relatives, and they want to bring their friends. So we definitely have a history of that at my site.
Yeah, absolutely. We do, like you said, having the kids of the kids coming back in. Just the day before yesterday, before I left to come out, I was helping to do an ultrasound, just a first trimester dating ultrasound on a patient, and her mother was there saying, "Oh, this is a lot better than the machine you had when I was here. You couldn't see anything on that." I had to get 3 before they told me it was a girl. So, yeah, it's been really rewarding to get to see people so happy with the care that they come back in every generation.
And that did just make me think of all of the systems we have in place that aren't always easily recognizable, but really support the amazing stories that our providers are able to tell. So just recently, we realized that it wasn't always easy for patients to change primary care providers, and we really want entire families to see the same provider. And so we just recently tried to make sure that we had systems in place so that it's easier if a patient calls us and wants to switch providers because their husband or wife or kids see that provider. We let our call center do it automatically, which was something we didn't do in the past. We had this whole process of steps that they had to follow to request changing their provider. And we realized that that was actually not helping us with continuity or family-based care or building those relationships. And so we made sure that we changed that process and made it easier. It looks like we have a question there.
Several aha moments at this conference, but the idea of the group visits, just like, wow, that's such a great idea. So 2 questions. One, does that count as a visit for Medicare, Medicaid? And then the other question is if I want to find out more, like, for example, what the flow would be for a diabetes meeting. And I just have so many people with back pain when they come in. I just groan because we don't have any good options. So do you have a behavioral health at both the diabetes and the back pain meetings, or just the...
Typically, a case manager works with the provider for the diabetes meetings, although BHPs can step in if needed. But our case managers have a little bit more specialized training, and then BHPs will come in as needed and also to be able to be consulting on the comorbidity of depression and diabetes. For our pain management groups, it is a BHP with the provider at this point. But we try to work together as best as we can. I'm not sure about the Medicaid.
Yeah, it depends on the type of group that we have and what types of providers are there. But when the providers do have one-on-one interactions with the patient, we are able to bill for that if there's a medical provider in the visit. But our group visits again take an incredible amount of coordination, and the entire team is involved. Like Lauren said, from the case manager helping to recruit patients, set up the group, make sure they understand what's going to happen. We do a lot of training. We use the centering pregnancy model. So our staff have a lot of training in that and how to facilitate groups. And like Dr. O'Brien was talking about, we really help work with our case managers and providers and behavioral health professionals on facilitating groups and letting patients really drive the conversations and not just using it as a class to just come and talk, with like a didactic, but really have it be an interaction between all of the patients and their different providers that are attending the groups.
If I can just say one note on that just really quickly. For the flow as the provider, I think it's actually really nice to have the group visits. Typically, we just sit in a circle. It's kind of the flow. And either one of the nurses or the case managers will be making a presentation for, 15, 20, 30 minutes, whatever that might be. And I think kind of the benefit in it is all in the pre-work. Through our EHR, every patient has a diabetes registry which shows what's their A1C, when was their last microalbumin, when was their last lipids, is their blood pressure at goal, have they had their Pneumovax, have they had their Tdap, and their influenza. As well as a foot check and a retinal photo and things like that. So it's reimbursable to the clinic as a physician because I check that page and I go around one at a time and just say, hey, Mr. Jones, you need a microalbumin. Did you get your A1C down a little bit? How have your sugars been going since last time? Everything's good? Great. And move on. And so in just a couple of minutes, you can briefly check in with everybody. And so you can build 10 or 12 99213 visits very successfully in a fraction of the time and have a really rewarding experience for your patients too. So.
Can you talk some more about patient activation, how you achieve that in your clinic and how you're measuring that?
Sure. I think the number one thing that we measure around patient activation is our patients with self-management goals. And so our case managers do the most self-management goal setting with our patients, but everybody in the clinic can do it. And again, it's in our EHR. You can see for our patients that have self-management goals, and we're really conscientious about following up on those. And again, I just recently attended one of our case manager trainings where we were talking to them about self-management goals. And we really work with them to make sure that they're meeting the patients where they're at and setting goals that the patient actually wants to set. So we don't have them go in the room and say, well, it looks like you need to exercise more. What goal would you like to set around exercise? They ask them, what's something you would like to do to improve your health? And we really let the patients drive those decisions and tell us what kind of support they need. So I think that self-management is definitely the largest thing we do around patient activation.
I think that the chronic disease management templates are really helpful as well. Through the EHR, every patient with diabetes or with hypertension is automatically added to a registry. And so the case manager periodically goes through and checks everybody. Have you been in for your blood pressure check in the last 3 months? Or was it a 6-month goal? For our diabetic patients, have you had an A1C in the last 6 months? Have you had a Pneumovax? Have you had your influenza shot this year? So I think it gives you, the provider, a sense of control, which is nice, in that there's a plan for this person. You're not just sitting waiting for a disaster to come in. You're actively bringing people in to try to prevent trouble. So.
Hi, thank you for your presentation so far. I'm a nurse practitioner at a community health center that's really growing exponentially. So continuity has been a huge issue, having patients being able to get back to me. And I think we have right now something called an open access. So unfortunately, though, you can't see me. You can only book out 3 days right now. And so patients call every 8 o'clock in the morning, and my panel is already filled up. And so we're trying to look at other models we have to change. They went to that model because there were so many no-shows initially. And so now we're like, okay, we have to do something else. Can you speak a little bit about what you guys do for continuity in terms of getting patients to be able to book with their clinicians?
Sure. I think the foundation is having panels and limiting the panel size. So we try to make sure that we only assign as many patients to a provider that they can see so that they are able to have access for the patients that we've assigned to them. So I think it kind of starts with really managing our panels, and it's something that takes a lot of effort. So every time we have turnover or hire new providers, we're constantly looking to see how many patients are assigned to our various providers and looking to see if we need to make any adjustments so that they're able to come in and see their providers. And then, we try really hard to work with our teams to do today's work today. So we do lean on our nurses quite a bit to, when the call center is not able to book an appointment, it sounds like we have similar situations where provider schedules are full for today or maybe even a couple of days out. And we really do try to transfer those patients to the care team and let the team figure out how they're going to meet that patient's needs for that day. And it might be that the nurse brings them in and tries to do as much of the workup as possible and do what we call a co-visit, where the provider only needs to come in for a little while. Or, we just try to make sure that we are having conversations about where is it okay to double book today. And then again, sometimes I think you can get stuck in that day-to-day chaos or emergencies of trying to do all of today's work today. And some of the long-term, more system-level planning is what eventually would help with that. So like I said, during the summer, we try to really work our registries hard and make sure we do as much planned care and just chronic care as we can, so that during the busier times, our schedules aren't quite as full. So we use a lot of different strategies to try to manage access, but we certainly have very similar issues. I'm sure you guys have.
One thing that I've done a few times on the pods that I've worked at is if a patient's calling and requesting and demanding to be seen, and the provider and I know this patient has lots of psychosocial stressors, lots has been going on, or if I have a relationship with them especially, I'll have them come on in. We'll meet in one of the counseling rooms. I'll try to figure out what is really going on for today, and then I can step out and consult with the provider. The provider has come in the therapy room with me at times too, just to do those quick contacts, those co-visits, if the medication isn't working for their depression or anxiety or something else comes up, or if it's really they just need to talk and figure out kind of what stress is going on right now, how to manage it. That's something that I can step in and do, and that's been something we've been doing more and more when patients do sometimes just walk in saying, I need to see this person now. And if I can help with that, or the case manager will step in, and that can help the provider keep their flow for the day.
Our booking system right now, I'd love to hear if anybody has one that works better, but has been that people can book 2 weeks in advance. You can have any appointment you want within the 2 weeks, but you can't book beyond it, because we had the no-show problem as well. There's a morning and an afternoon session, just like anywhere. We leave one appointment open every morning and one every afternoon for walk-in or urgent visits. And we say we want people seen by their primary care doctor, and of course we do, or their primary provider, nurse practitioner. But I think more often than not, what we really achieve is that the people get seen by their pod. Myself, there is another nurse practitioner there and another physician. And, they see the same medical assistants, the same nurse. And so it's almost more of they're seeing the pod, and that seems to help out quite a bit as well. So good luck.
I had a question regarding how do you fund this sort of thing? Like if you wanted to start a group visit, if you wanted a behavioral health, I don't know how they work with the billing. Did you have to get a grant? How did you set up the registries?
Sure.
It sounds like money.
Yeah, we have a lot of very generous donors in Colorado for sure. The Colorado Health Foundation has given us a lot of money to help support the work that we do. And then we have some really neat collaborations. So we're part of the Integrated Physician Network, which is a group of private practice providers that we share an EHR with. And the hospital helps to cover some of our licensing fees. We work really closely with the mental health centers in our various counties, and they actually help us with some of our staffing. So they give us some behavioral health providers that actually sit on our pods but work for the mental health center. I think our funding comes from a lot of different areas. We have an amazing I was going to say department. We have 2 people that work in our development department that just do an incredible job of helping us to find funding. We get some private donations, and then we really do work hard to make sure that we're billing for everything that we can bill for, and that we're getting as much revenue as possible with the providers that we do have. But it's not a cheap model by any means. We have a lot of staff on our pods. And, Is there, did you say there's a question that?
I think that might have been her.
Oh, okay.
Yeah. One thing, too, I think we're progressively trying to do more is have evidence-based models of care, being able to measure our outcomes. And even as a behavioral health professional, that can feel gray and hard to do. But we have PHQs and different measures and tools that we use. So to our funders or potential funders or grants that we're looking for, we have these measures that show this is how many patients we get to see, this is what's improving. And I think that helps with the funding, because because people are getting better, not just with their diabetes, but also with their depression or their chronic pain. We're able to show the whole picture of a patient's improvement.
I work for an FQHC. Is that the same?
Yeah.
And I'm curious about two things. The shared medical visit, we just started doing that for diabetes also. I'm a psychologist. And you sit in a group around the table. How do you deal with confidentiality? Because we were struggling with that, with the doctor sitting in there and saying, okay, did you check your A1Cs? Did you do this? Did you do that? With all the other people in the group. And then my second question was, how did you manage to get a case manager? Because they will not, they keep telling us we can't bill for their services. So any ideas would be great.
Do you want to take the question about confidentiality in groups?
Sure. I wish I had a good answer for you on that. If there's anything to be discussed that seems personal beyond, like, you know, I think you should increase your metformin from 500 to 1,000, or I think you should probably not have, 6 beers every night, whatever it might be. There is a small room where I take the patient aside and try to talk to them individually. I think within our community, some of these group co-visits now have been going on for 8 or 10 years sometimes in some of my patients, and so they're pretty comfortable talking to each other. I might have my head in the sand a little bit, but I guess I kind of take my lead from them that they don't seem to have any problem sharing all kinds of intimate things with each other. So, yeah, it hasn't been an issue so far. But I totally agree. I think if it's anything that, in your judgment, seems to need confidentiality, we do have a small exam room off to the side that we take them to. So.
And the case manager that's helping facilitate those meetings, or the BHP, at the very first session, they review what is confidentiality, what are our group guidelines, how do we be respectful together here in this learning environment. And that's something that's revisited in the group visits also by the case manager to keep people on the same page. So that's something that we try to address. I'm not sure if there's a specific disclosure form that they sign. I know for the anxiety group that I do and other stress management groups, that's something that they specifically sign and that we discuss, but it's more of a therapeutic class group thing. But that's something that we want to acknowledge that patients, and if they're not comfortable, they can choose to opt out of that group visit.
But yeah, I think it's just really patient-led, and like Lauren said, that they decide as a group kind of what their norms are, and they make agreements about not sharing confidential information. And then as far as case managers, we can't bill for their services, but especially lately, we have one case manager per pod, and we actually want to add more. So we've started hiring a couple more, and the way that we're funding that is through accountable care. So in Colorado, our Medicaid is doing an accountable care collaborative, and so we're participating in the very beginnings of that and starting to get a small per member per month fee for our patients that are a part of that, and we want to use that money to beef up our case management staffing. Okay. Oh no, go ahead.
I have a couple of questions. I'm a physician in a rural health clinic, and we're in the beginning stages of initiating the patient-centered medical home. One is, I had a question about how do you guys go about, coordinating the care with the local hospitals and specialists as far as your referral systems, and having that connection with the hospitals as far as the patients that may be admitted to the hospital when they're discharged and admitted. And then the second question is, how did you go about providing after-hours care? What is that process for you guys? Extended hours, after-hours care?
Sure. So we have a really close relationship with one hospital in particular where our providers round, and so I'm sorry, did you just wanted to know how we have strong relationships with the hospital?
As far as I'm in a rural clinic, so we're in the process of, we have a hospital that's 40 miles away. So we have subspecialists that we have to refer to either 3 hours away or the 45 minutes away that accept our patient's insurance. So we do like Medicaid, Medicare type of insurance. And so how do you integrate that into as it relates to your EMR? As far as, do you have access to their system? Do they have access to yours as far as knowing who your patients are, if they have to be admitted and things like that?
Sure. So we are really lucky in that we have a very close relationship with one hospital in particular, and our providers round and deliver there as well, and we share our EHR with them. So that it just really facilitates communication because we are all a part of the same group. But we really struggle with access to specialists for our patients. And like Dr. O'Brien was saying, our referral case managers really get out there and they are just literally calling around, begging, trying to find services for our patients. We certainly have lots of generous specialists that help us out or that our providers have relationships with that they can work out arrangements for our patients. And we're just starting to work a little more closely with Kaiser Permanente in Colorado. They want to know how they can help provide better access to specialty care through their specialists. But it's something that is really challenging for us as well to coordinate that kind of care.
Yeah, I completely agree. I don't want to sugarcoat it. Like, we have a lot of trouble getting, especially surgical care for our patients. We're lucky in that we have a few specialists who donate their time. Rheumatology. We have an ear, nose, and throat doctor who spends 1 day a week in our clinic. There's a cardiologist who periodically comes through. But in terms of, this person needs whatever it is, a nephrectomy or a cholecystectomy or something, it is tough, for sure. Usually more often than not, they're on the phone. They just got to want it. They've got to set it up financially with the hospital, with the anesthesia group, with the surgeon, a payment plan. And it is tough, for sure. We do have it sounds like your situation's a little different. At least our clinic in Lafayette is only about 5 or 10 minutes from the hospital we usually admit to. So if you're able to have anybody in your organization who wants to still have hospital privileges and round on your patients and have that part of the whole game, it helps a lot in terms of maintaining the relationship with the hospital. The head of the family medicine committee at the hospital is a Clinica doctor, and I think the second in command is too, and probably everybody else. So it does help quite a bit. We have remote access to their records. As being hospital privileged, you can remotely look up the records and labs. And if not, they electronically send everything to our record. So.
And then for after-hours care, our clinics do have some evening hours. We use an outside nurse advice line, and then our nurse advice line can contact our on-call providers when they need to. So we have some rules around that.
And then, I'm sorry, and then we set up an evening clinic for after-hours care, a big part of the patient-centered medical home. For me, I'm in the clinic 4 days a week. One of them's a late night, so I get to take a morning off.
Was similar to hers about doing the referrals. And so since you answered it, for the most part, I thought maybe you could give us an example on how you might have overcome a situation where you needed to get a patient in for a referral. We don't have case managers, so it's my nurse that usually calls and tries to get this patient in. And when Dr. Smith says, no, they're not seeing him, my nurse says, okay, and hangs up the phone. And a lot of times, we don't have any resources or thoughts about how to overcome that barrier. And then I had another question, just since you mentioned the after hours. As an FQHC, there's regulations as to services you can bill for, like telephone visits aren't a billable service. Are after hours services billable as they would be, say, in a private care, urgent care setting?
So the telephone calls that we do are not if we just communicate with the patient by phone. But we do just have our normal clinic open just a little bit later. So depending on the day of the week in the clinic, we just try to have regular appointment slots available into the evening is the way that we handle that. And those work the same way as any of our other visits.
Like I worked urgent care before I ever came to an FQHC, and there was like a S9008 code or something, and that's a after-hours service code. And it's a billable service on top of your normal, 99213 code. So I didn't know if that was something you guys utilize for your after-hours services, or if it's even allowable. You don't know or don't use it.
I don't believe so. I don't think so.
I was wondering, since you mentioned it, we don't do any of those billable services after hours, but if we wanted to incorporate it, I was just wondering. But if you could just touch on the referral thing.
I wish I had a better answer about the referrals other than we have staff that work really hard to try to find our patients what they need. And it's literally by calling around and talking to our providers about people they might know or
Yeah. I think you got a whole lot of blank stares with the after-hour code up here, kind of like the deer in headlights. Like, I don't know. I just bill my 99213s or 14s and kind of get on with the day. But for referrals, I think, man, there's nothing like you, the physician or PA or nurse practitioner, picking up the phone and kind of just holding the specialist to it. You know, we've had cases where people come out of the hospital and they've had a nephrostomy tube placed by urology, and then that specialist office won't see them to take it out, so they're just stuck with a hose coming out of their back. You know, and it's a bummer, for sure. I think it just comes down to you picking up the phone and saying, what are you going to do but to fix this? You know, and we all know the private insurance people get basically whatever they want. Medicare, Medicaid has 1 or 2 people in town. And I've found there's usually one specialist in each area that will take a cash payment. And it's about how motivated are your patients to see them. Can they swing $80, $125, whatever it's going to be to see this patient? And more often than not, they can at least have some kind of visit.
I think we're out of time. I don't know if there's other questions or if we could maybe take one more. It looks like there's one more. Yeah, okay.
I just had, hi, the microphone. I'm a family physician, osteopathic in Fort Lauderdale, Florida. And I had a question about the limiting of the patient panels, because that sounds like a phenomenal idea, but I was wondering how it actually translated into, number one, how many patients do the doctors actually see or providers actually see for the day? And number two, does that mean that you actually turn away people? Because at our center, we were told, you know, you cannot limit patient panels at all. That's kind of like a taboo thing to talk about, because they say that, you know, we can't turn anyone away, number one, and number two, we have to see a certain amount per day. So I was wondering how you achieve that.
Sure. So we do keep a wait list. We could not possibly see everybody that needs to see us in our service area. And as soon as we're able, we're calling those people back and getting them in. And we try to have as many systems in place to make sure that we're seeing them when we can. And, you know, every time there's an opportunity, we apply for a new access point and try to continue to grow and add providers. But we could not see everybody that needs to see us. And our providers, they average about 17 visits a day, an 8-hour day. And, you know, that can really vary anywhere between over 20 and, you know, about 15, depending on the day.
It sounds wonderful, and I don't know if it's achievable because our managers tell us, you know, we are obligated to see everybody that wants to be seen, so that essentially means a waiting time of literally like 3 to 6 months to come in and get a visit. And so it doesn't, I mean, I see my patients sort of when I want to, but it means overbooking, triple booking, quadruple booking my schedule, and I've never been there a day when I've seen 17 patients. It's always, you know, closer to 25 to 30.
Right. So. Yeah, you know, I think it sounds like maybe essentially the same thing ends up happening for some of the patients in our community, where they're waiting to get in to see you for 3 to 6 months on your schedule. We just have a conversation with them when they call for an appointment, if it's a new patient, to let them know that we want to provide you care and we want to do a really great job at it. So when we have a spot for you, we're going to call you back. And hopefully that wait is about the same, you know, 3 to 6 months.
It makes so much more sense the way you're doing it.
And just the last thing I'll mention is, because I think our administration really values the sustainability of the practitioners staying in the field and at our sites, that we understand that the limits are also so we can take care of ourselves to keep giving this good care. And that's why we have case managers or BHPs or nurses, so we can help share that demand, because it's just so high, and it is tricky.